この1時間余りですかね、プレゼンシャルレクチャーということで、will be addressed by the president of this meeting, Dr. Shiina. And Shuichiro Shiina graduated medical school in 1982, University of Tokyo. And he started the trainings. When I first met him was 1992. But before that, amazingly, he did some basic studies. Actually, there was a doctor, his name is Dr. Shiratori. He used to be chairman of the department, first department in Okayama University, but because of his sickness, he had an early retirement. But with after the basic research of with Dr. Shiratori, Dr. Shiina started the percutaneous treatment at Mitsui hospitals. Then he came back to the University of Tokyo. That's the time I met him, 1992. So after that, almost 26 years, he's been in this field for many, many years. And maybe, I'm sure, he's the one who did most RFA for the patient with the hepatocellular carcinoma. So today's topics are ablation of hepatocellular carcinoma for the 30 years. So Dr. Shiina, please.
Thank you, Professor Omata, and thank you for everyone. So today I would like to talk about my experience for ablation therapy for hepatocellular carcinoma. I started ablation therapies, first ethanol injection in 1985. Then I moved from first generation microwave ablation and radiofrequency ablation. But the basic concept and the techniques are the same. So I would like to summarize my experience. So various non-surgical therapies have been introduced for hepatocellular carcinoma. Among these, image-guided percutaneous ablations are considered best for early-stage hepatocellular carcinoma. They include ethanol injection, microwave ablation, and radiofrequency ablation, IRE and cryoablation, and others. I started ethanol injection in 1985. Percutaneous ethanol injection was the first reported in the early 1980s by Chiba Group in Japan and had long been the standard in ablation therapy. This is my first report about ethanol injection. This is a short-term efficacy of ethanol injections. And then I presented this is the first report of long-term outcomes of ethanol injections. And this is the first review of ethanol injection. At that time, I had a lot of time, so I had enough time to write manuscript. But this is the histopathological examination after ethanol injection. And we developed a multiple needle insertion method for large tumors. And this slide showed that we could ablate successfully of large tumors up to 10 centimeters or sometimes more than 10 centimeters in diameter by using multiple needles. And this is the long-term survival of ethanol injection in 146 patients at that time. Ethanol injection was a good treatment, but somewhat more complicated compared with radiofrequency ablation. This is paper is published in 2012, which shows about 20-year outcomes of ethanol injection, which shows ethanol injection was potentially curative for hepatocellular carcinoma, resulting in survival for more than 20 years. In 168 patients with primary hepatocellular carcinoma who underwent radiofrequency ablation, with a median follow-up of 51.6 months, 5, 10, and 20-year survivors were 49%, 17.9%, and 7.2%. And we used the first generation microwave ablation in 1990s. However, there are some limitations, so we shifted to radiofrequency ablation. This is the first day that we performed radiofrequency ablation. So radiofrequency ablation had an advantage of ethanol injection, which can ablate a large volume of tissue in one treatment, as well as an advantage of microwave ablation, which can surely ablate a certain volume. And several randomized controlled trials have demonstrated that radiofrequency ablation is superior to ethanol injection. In our radiofrequency randomized controlled trial, radiofrequency ablation had a 46% smaller risk of death and 88% smaller risk of local tumor progression than ethanol injection. This slide shows the transition of percutaneous tumor ablation for liver tumors at the University of Tokyo, my alma mater. There was a drastic shift from ethanol injection first generation microwave ablation to radiofrequency ablation after the introduction of radiofrequency ablation. And this slide shows the top 20 RFA institutes in Japan in 2012. At that time, the University of Tokyo had the largest number, which is more than almost twice of that of the second institution, which is the NTT East Japan, where Dr. Teratani performed radiofrequency ablation. Dr. Teratani is my colleague, and there are several hospital facilities where doctors who had taken our training course for more than 6 months. And this slide shows the indication of radiofrequency ablation. Of course, the preferable indication is cases of child Q class A or B, a single tumor of 5 centimeters or less in diameter, or 3 or fewer tumors 3 centimeters or less in diameter. However, in cases beyond these conditions, we perform RFA on patients who are likely to benefit from this procedure for possible cure or prolongation of life. So we have performed radiofrequency ablation as the first line therapy in almost 90% of the patients. And this is actually our second case of RFA. We did RFA in February 1999. So that means 19 years ago. 48-year-old man was found to have a lesion of 3.6 centimeters adjacent to infravena cava. Many doctors who performed microwave ablation said so because of the heat sink effect, tumors adjacent to large vessels cannot be ablated completely because of the heat sink effect. But however, we could ablate this tumor from the beginning. It was 19 years ago, but we ablated the tumor completely, as you know. And this slide shows our anti-tumor effect of radiofrequency ablation. Complete ablation was achieved 99.4%, that is, of the treatment. So in our groups, as a general rule, we repeat radiofrequency ablation until complete tumor ablation is achieved. In other groups, they limit their number of sessions, but in our group, that's why we can achieve the complete ablation in almost all cases, probably. I would like to show a case. This is a man who was found to have hepatocellular carcinoma. This is a CTAP, which shows a tumor of 3.5 centimeter near the porta hepatis. And he refused surgery, and we performed radiofrequency ablation. This is the CT during arterial portography, so we can see the tumor as a defect. And this slide shows shows CT after the first RFA, which shows that the region was covered with non-enhanced area. However, there was a small lipidol deposit here, outside of the ablated area. So we decided to perform additional radiofrequency ablation. In this case, we didn't combine embolization, chemoembolization, TACE. No, we just infused lipidol. And this is a CT after the second radiofrequency ablation. We judged further treatment would be unnecessary because CT confirmed that the adequate amount of tissue all around the tumor had been ablated. And this is our long-term effect of radiofrequency ablation. Survival of 1,616 patients who underwent radiofrequency ablation for hepatocellular carcinoma. The survival rate were 62.3% at 5 years, 28% at 10 years, and 15% at 15 years. Multivariate analysis demonstrated that age, anti-HCV Child-Pugh score, the liver function, tumor size, tumor number, serum DCP and levels, and serum AFP-L3 levels were significantly related to survival. And this slide shows the accumulated number of RFA treatment at the University of Tokyo and at the Juntendo University. The number of RFA cases at the University of Tokyo reached 10,000 in September 15th, 2016. This is probably the first institution which performed RFA for 10,000 cases. And now I moved to Juntendo University, and we have, last year we have 660 cases of RFA at Juntendo University. Since the ethanol injection period, we have had strong argument regarding which is superior for HCC, surgical resection or percutaneous ablations. We had a very strong competition with surgeons. This slide shows the treatment algorithm for HCC in clinical practice guideline for HCC in Japan. Both hepatectomy and local tumor ablations are treatment of choice in tumors 3 centimeters or 3 or fewer tumors, each 3 centimeters or less in diameter. However, this slide shows the top 20 hospitals in Japan on RFA and surgical resection. There were 40 hospitals which performed RFA over 100 cases a year. On the other hand, there are only 3 hospitals which perform surgical resection over 100 cases a year. RFA is much more widely practiced in Japan. So patients prefer ablation to surgical resection. And this slide shows a recent nationwide survey in Japan. In radiofrequency ablation, 5-year survival rate was 58%, while in surgical resection, 5-year survival rate was 57%. Of course, the baseline characteristics were different between the 2 therapies. So it's not it's rather complicated to compare the outcome in both therapies. But patients with older age or poor liver dysfunction tend to undergo radiofrequency ablation, and patients with larger tumor size tend to undergo surgical resection. So from these data nowadays in Japan, many doctors think the RFA and ablation and surgical resection would not be different so much, even from the long-term survival. Okay, so we are sure that competition as well as cooperation with surgical surgeons have been invaluable to refine our ablations. These are the doctors at the University of Tokyo and others who are acknowledged as world-leading hepatobiliary surgeons by themselves and as well as by others. I'd like to refer a little about the RFA for liver metastasis, especially for colorectal liver mets. We perform RFA on patients who are likely to benefit from this procedure. So we performed RFA not only as a potentially curative treatment, but also as a cytoreductive treatment. This slide shows our overall survival of 204 colorectal liver mets patients who underwent radiofrequency ablation. The survival rate was 38% at 5 years and 22% at 10 years. I would like to show a few demonstrable cases. This is a woman who underwent RFA and survived without recurrence for over 15 years until at the age of 98. She underwent MICE operation in 1996 and hepatic resection 1 year later. But after a year later, she developed a new liver metastasis of 1 centimeter in diameter. But she declined surgery because she's over 80 years and she didn't want to undergo abdominal surgery, open laparotomy for 3 times. And she was followed without any treatment. In March 2000, she was referred to us for radiofrequency ablation. At that time, the liver metastasis grown up to 3.6 centimeters. And this is a CT after radiofrequency ablation, which showed complete necrosis of the tumor with safety margin. And she survived for more than 15 years until at the age of 98. So this case clearly shows radiofrequency ablation therapy could be a treatment of curative treatment if we perform precisely, properly. And this is a 68-year-old man with multiple liver mets and peritoneal dissemination and spleen mets. He underwent a hepatectomy two times, and then multiple liver mets and peritoneal dissemination were detected. So systemic chemotherapy started, but he visited us for further treatment. But because of this condition, we recommended him continuation of chemotherapy. But the result of the chemotherapy was progressive disease. So he visited our department again, and we decided to perform radiofrequency ablation for site reduction followed by chemotherapy. This is the actual slide, CT scan. He had at least 7 liver mets, 1 spleen met, and 15 peritoneal disseminated lesions. He could never be a candidate for surgical resection. Yeah, actually we can see seedings here. This is probably the largest seeding. By using the artificial ascites and other techniques, we could ablate all detected lesions except one, this disseminated lesion of 1.5 centimeter in the omentum. Thereafter, we performed iterative RFA when new tumors were detected. He had survived for 26 months. So, regarding RFA for colorectal liver metastasis, our 10-year experience showed that radiofrequency ablation for colorectal liver metastasis is a potentially curative treatment, resulting in long-term survival as long as over 10 years, although many patients treated by radiofrequency ablation had unfavorable conditions for survival. I would like to refer to RFA for tumors outside of the liver a little. This is a case of unresectable large intrapelvic recurrence of HCC treated by RFA in 2008. He is from Kuwait, and he underwent nephrectomy in March 2008, but he had been diagnosed as having locally recurrent kidney cancer later, and when he had visited a German hospital, his cancer had been judged unresectable, and chemotherapy was recommended. Cancer pain had gradually worsened and became intolerable despite sunitinib therapies. So he visited us in December 2008, and his cancer was almost 10 centimeters, and our surgeon also judged that the cancer was difficult to be cured, even if they would remove the right hemipelvis and the right leg. So we decided to perform radiofrequency ablation for his intrapelvic recurrence of renal cell carcinoma. We performed RFA 4 sessions under ultrasound guidance using an artificial ascites technique to avoid the injury of the intestines. Our total ablation time was 184 minutes. And the final CT showed no apparent viable portion in the tumor. No complication occurred. And after RFA, his pain disappeared, and he stopped chemotherapy because it hadn't worked. And he has visited us periodically. He has survived for over 9 years without recurrence. This is the recent CT scan. And so, regarding ablation for tumors outside of the liver, in the future, there's a possibility in Japan of widening the indication of ablation in other fields than malignant liver tumors. Nowadays, only malignant liver tumors are covered by public health insurance, but in the near future, it will be other tumors can be covered by public health insurance. Various innovations and sophisticated instruments would further improve the outcomes of radiofrequency ablation. This is our dedicated ultrasound transducer for interventional procedures. And ultrasound contrast agent is also important, and this is our dedicated procedure bed, which we can give the patient almost a standing position, and multimodality fusion imaging is also important. This dedicated ultrasound transducer is developed in cooperation with Toshiba, and we have performed RFA on over 10,000 cases of liver tumors using this ultrasound probe. And contrast-enhanced ultrasound is also important, as you know, to detect the viable portion, to separate the differentiate the viable portion from the non-viable part. I'd like to show a case. This is the even after artificial pleural fusion method, with B-mode ultrasound, we cannot detect the viable portions we cannot identify the viable portions. But by using the contrast-enhanced ultrasound, vascular imaging shows hypervascular area, which represents the residual cancer, and we can insert the electrode without delay. And the CT after RFA demonstrate complete destruction of the viable portion in segment 7. And this is our dedicated procedure bed. We developed this bed, and using this bed, we can keep a patient in an optimal position. Sometimes this standing position would be very useful to ablate a tumor in especially in the left lobe or in the caudate lobe. Okay? And multimodality fusion imaging would further improve radiofrequency ablation. This is the system to merge real-time ultrasound with previously acquired CT, MR, or ultrasound images. And incidentally, radiofrequency ablation is highly operator dependent. Its skills and outcomes are very different from operator to operator or from institution to institution. So, in order to disseminate skills and know-hows for radiofrequency ablation therapies, we have held training programs. Programs are composed of comprehensive lectures, live demonstrations, and case studies. Context of the lectures are current status of RFA devices, ultrasonography, indication of RFA, complications of RFA, and others. And the this shows the ultrasound exam by the participant. Ultrasound exams are also done by participants on patients who would undergo radiofrequency ablation on the next day. And we perform RFA on 2 or 3 cases on a half day using artificial ascites, artificial pleural effusion, contrast-enhanced ultrasound, guidance, and diffusion imaging method. So in the international course, we shows around 15 cases of the 15 to 20 cases of live demonstrations. I would like to show a case. This is a case on which we did RFA in the 5th RFA domestic training program. 68-year-old women with 2 colorectal liver mets. One was in segment 4 to 8, continuous with middle hepatic vein, and the other was adjacent to the heart. Continuous with the middle hepatic. This is here is a tumor adjacent to the heart, and I'd like to show how we perform. This is our regular case, so that's why we performed radiofrequency ablation, not a special case. The patients was in a almost standing position, and we put our dedicated ultrasound probe obliquely in the epigastrium and detected the lesion and punctured it. Okay. Here, we can see the tumor here, adjacent to the heart. The other tumor is here, continuous with the middle hepatic vein. And by having Oh. This is not a special case for us. We routinely performed RFA on cases like this, so that's why we showed this case in our live demonstration. Actually, we don't choose any case. And we use, by using the contrast enhance, and by using the, Doppler ultrasound, we detect whether there is a reflux of blood or not. And this CT scan after RFA showed complete ablation of the two tumors. The region adjacent to the heart, the tumor continuous with the middle hepatic vein. We could ablate both tumors successfully. And in case studies, difficult to ablate cases from participants' hospitals are presented and discussed. And this slide shows a total of 170 participants in the first to 10th Juntendo RFA training programs. And we will have the 11th RFA training programs in this year, June 22nd to 23rd, 2-day training program. And we also have international RFA training programs. So far, we have had 4 international RFA training programs, and there were 49 participants outside of Japan. I would like to show a video to show. I'd like to start the course introduction now. So, radiofrequency ablation is a standard treatment modality for liver tumors.
We want to improve curability. The safety may be compromised, and we may have to restrict indication criteria.
Used for when the tumor located near the diaphragm, such as segment 7 and segment 8.
First case is 85 years old female, HCC. She is HCC.
So tomorrow, first we use sonazole.
So now I'd like to say kanpai. So I can say kanpai. Kanpai. Okay. So this is the post-RFA, and here we can see a slide I put in this here. So we ablate this portion, but we don't ablate the left side nodule.
So usually you begin with maybe the larger side. You begin with higher power, or the same from P.
No. It's not depend on the size of the tumor. It depends on the length of the needle. front view and right side first. From the next training program, we would use not only RFA but also microwave ablation. And our next domestic training program may be held in July 22nd and 23rd, and our international IBO interventional oncology training program will be held on August 21st, 20 to 25, or like that. So, August 25th, from August 21st and 25th, we'll have an international interventional oncology training program, in which we will show both radiofrequency ablation and microwave ablation. And we are now entering the new era in ablation therapies. So after this session, you will have the special symposium entitled Current Status of Ablation. In this session, we requested even companies whose ablation systems are not being commercially available in Asia to make presentations. They have agreed to actively cooperate with us in APASL Single Topic Conference, Yokohama. The largest number of treatments using ablation therapies are now performed in the Asian Pacific region at present, and the future development is expected in this region. So, Asia has the largest number of ablation procedures in the world, and hepatocellular carcinoma is the most common disease treated by ablation. And we have ACTA, Asian Conference on Tumor Ablation, every year too, and update knowledge, share experience, develop guidelines, and provide education. So, and this year ACTA will be held in India. So, and I would like to summarize my talk. Outcomes in over 10-year period clearly shows that ablation is a curative treatment and elongate long-term survival. Competitions as well as cooperation with surgeons has been invaluable to refine our ablations. Various innovations would further improve outcomes in ablations. Training programs may be useful to provide opportunities to understand basic concepts and learn essential technical tips for successful ablation. We would like not only medical professions, but also companies in healthcare fields to support ablations. And in conclusion, sophisticated ablation, which is potentially curative, minimally invasive, and easily repeatable for recurrence, would be an alternative surgery for small and possibly for middle-sized hepatocellular carcinoma and other liver tumors. Thank you very much.
Well, thank you very much, Dr. Shiina. It was very impressive because for such a long time, concentrated on one thing. It's amazing things. Maybe there is some time, so may I take some question? Because this is Asian Pacific Association for the Study of Liver Diseases, and then situation may vary because this is his story, but any comments, especially the surgeons or the hepatologist or radiologist, whoever? Because the situation is somewhat different, because in Japan, we can do everything. Even the hepatologist can have ultrasound. That's why he can develop things. But some countries, societies, differences. So in China, for example, I think hepatologists cannot have the ultrasound at hand. Weilai, do you have any comments? Dr. Weilai from Beijing.
Yes. Very, very impressive. And for the long history and the multi and the training program and the participates, and also and the provide many and the evidence to support and the radio frequency could be a cure and methods for the hepatocellular carcinoma. And of course, it's based on your and the Professor Shiina, the long-term concentrating and professional, and also some and the very good and the policy. And Professor Omata mentioned and the what's the policy for China, and some policy and they changed. And a long time ago, and the hepatology can do the ultrasound, and actually, and the many doctor can't do that. But recently, and the central government emphasized for the license, doctor can own and only one license, hepatology or ultrasound, which you prefer. But actually, and I think, and in addition to ultrasound, even the hepatologists in China, such as in all department, and we also can do and the radio frequency for the patients. So I think, and it's a hepatology, and just for this meeting, and also for the long history, and Professor Omata making APASL a big family. When we did the last slide, today is a meeting, is a scientific program. I would say, and Professor Omata make the APASL a really hepatology. A hepatology not only the physician, hepatology coverage, it should include and the radio frequency and the radiology, and also for the surgery, and also for and other doctors, even for the liver study, and also the liver hairs, and also for the some and the research and the exchange of opinion and the meeting and the young guide training, or also the whole and Asia to join together, have the many chance for different aspects and different country and areas the young participants together. Anyway, and I think the professors share us and the experienced for long time and the experience research clinical practice give us some and the implication for all do something in the APASL under the Professor Omata and the guideline otherwise. Thank you.
Thank you, Joe. Well, I think he's saying that, the reason why he can do is maybe because we can find the tumor small. If the patient comes with advanced 5 centimeters, even the Shiina may have some difficulty, even though he does it. But in reality, if we can find a tumor small, like 2 to 3 centimeters, in the University of Tokyo, the average size of tumor we found 2.4 centimeters. Then we can stick the needle. So that's what Dr. Uehara is saying. By following the patients with high risks, you can eventually find out the tumor small at age 78. How come you have to submit the patient to the surgery? We found the tumors very small, and plenty of them. And then they recur. That's why we have the opportunities. So the situation have to be depend on the Asian countries. And then Dr. Shiina, why don't you go outside, inviting the people, youngsters in your place, but why don't you go out to China? Why don't you go to the Burma?
Yeah.
And then there are so many places they have a difficulty, and all of a sudden he shows up and showing how to do the things. They might be very much impressed. It doesn't matter whether it's a radiology department, it's a hepatology department. You should show that, because the dilemma was, even though you talk this, operator-oriented, you keep saying, they are not impressed, because that's your opinion. But when you show that your presence in China, in Burma, Myanmar, whatever, why don't you go there?
Okay.
Yeah, this dilemma is already been here for 40 years, because even though he gave a talk, they already, especially the Caucasian people, need the evidence. But patient is a patient. They don't want to die. So that's what he's doing. I'm very unfortunate to say that citation may be very important, but one patient is one patient. So Shiina, I think for the sake of patients, you should go around, not just sticking to the Juntendo Hospital.
Okay.
I'm not kidding. Look at
Okay.
Dr. Tanaka from Kyoto University. He's been in the Middle East for many years, many years. And then the introduction of the transplantation of liver, and then doing many good things for the Middle East people. So Shiina sensei, if you retire at Juntendo Hospital, I think a bunch of the people are going to prepare the position for you. And then I think time has come, so please have a contact with him, sending the youngsters to him, to his place, or invite him to be a place. Thank you very much.